doctor. I'm a pediatric doctor, and I'll just be going through a few SBAs relating to elements of pediatric dermatology, coupled with a few questions with children who have rashes and fevers. Okay, so we'll get started, and feel free to ask questions. I'll probably be better at answering things from a pediatric perspective than a dermatological perspective. And I'll answer any questions at the end, but feel free to post them. Okay. So as said, we'll cover things relating to pediatric dermatology, and some of those will cover rashes in children who are febrile. Now, just due to copyright issues, I don't have too many images on this PowerPoint, but all the images are copyright free, or they've been taken with Creative Commons licenses, most from Wikimedia Commons. But right at the end, just for those of you that do want some really good resources that you can access online or via your libraries, I will signpost you to a few really good places to go. So I offered to put this talk on partly because I think pediatric rashes just seem like a complete minefield of a topic. Either when you approach things from like a histological perspective, it's all a pink mess. And then when you look at a child in real life in clinic, that's also just pink and blotchy as well. And it's really hard to distinguish between all of these things on gross inspection straight away. So I think the first thing to point out is a lot of the time, no one's expecting you to get a spot diagnosis. And actually, for those of you that are purely assessment minded, you might not even get provided a picture in the first place. And that's because the key to tackling this topic is understanding the natural trajectory of the conditions. So knowing the detail of the history, knowing where the rash starts, where it spreads, its texture, whether it's accompanied with a fever or not, where does the rash go in relation to the fever. All of these things will be really helpful in helping you get the diagnosis. And actually, it's really satisfying once you know these conditions really well, because when you then are confronted with a child, actually taking quite a detailed history pretty much nails the diagnosis sometimes before you even get to look at the rash. And it does map out clinically really well. So I would encourage you to not just focus on very quickly doing a spot diagnosis, because a lot of the time you might not be able to, but actually paying some attention to the more sort of theoretical aspect of it as well. Okay, but I think it is daunting. It's daunting for medical students, it's daunting for foundation doctors, it's daunting for junior trainees, and even right up until as you become quite senior. I think rashes are a bit of a worrisome topic for a lot of people, but it's worth getting the basics down, and those go a long way. Okay, so we'll start off with the first question. So shall I give you a minute or so to read this and answer the question, and then we can pick up again? But it's a 4-year-old boy with a rash on his face. It's erythematous and weepy, and he's got a slight temperature. And it's asking, what is the most appropriate treatment? Shankar, are we going to launch the questions? So
yeah, so I'll launch it. I'll give them like 1 minute 30, because then it blocks up the question when you put it up.
Okay, sure. Okay.
Shall I end the poll now?
Yeah, I think that's going plenty of time. Okay. Oh, I think the options, yeah, I think for the next question, we might just need to write A, B, C, D, E.
So just 1 to 5 is A to E in that order.
Okay. All right, cool. So, okay, so we got a range of responses. There's pretty much an even split between the middle 3 options, B, C, and D. And then each where around 25 to 30% of you have gone for each of those, and roughly 10 to 15% have either gone for option A or E. So the correct answer here is D. Okay, so this here is the diagnosis the child has here is impetigo, and the description given in the question was quite a classical description. So impetigo is a rash that's typically caused by Staph aureus, but it's also caused by streptococci as well. And it typically starts off around the mouth or the nose, but it can usually then spread to other areas of the face in particular. It doesn't have to be confined to the face either. And the reason it has that golden crusting is very classical of Staph aureus. So for anyone who might know some Latin, aureus and aurum, meaning gold, have that same root. So for the most part, most staph infections, if they are simple, they can be treated with fusidic acid, which acts similarly to flucloxacillin, but you might also see some doctors giving flucloxacillin as well. Okay, so either fusidic acid or flucloxacillin would be a valid answer. And the key thing to note with impetigo is that it is highly contagious. Okay, so for that reason, you want to essentially advise the moment you see somebody with impetigo that they should be isolated from school or work, and they should not share towels at all, and really not be sharing like pillowcases or cushions and things like that. And they should be isolated until either the lesions crossed over or until they've had 48 hours of antibiotic therapy. Okay. Just to quickly explain why the other answers aren't correct. So paracetamol would be helpful in maybe in regulating temperatures, but in pediatrics, we don't tend to really give paracetamol unless it's really affecting the child and that the temperature is over 38. Acyclovir is used for viral infections, so that would not apply to impetigo. Hydrocortisone does have some role to play in impetigo, though it's not commonly used. And you wouldn't use hydrocortisone in isolation. For the most part, you would give fusidic acid or flucloxacillin, and that will suffice. And chlorhexidine and neomycin, well, you typically use things like that for like MRSA and things. And once again, we do not use anything like that for simple first-line treatment for impetigo. Okay. So going on to question 2, I'll give you a chance to read that and answer the question. Okay, so the most popular answer is half of you guys going for option C, 7 days, and then around 20% of you going for option D, and roughly 10% each going for the others. So the correct answer in this case is actually E. Okay, so the diagnosis here is chickenpox, and you can see here some vesicles at different stages. Some have dried over, crossed over, some have burst. And this is a fairly classical question, and it tests knowledge in different ways. So it's asking you to pick up that's chickenpox, and then you need to have some knowledge of chickenpox in particular over, firstly, how long the incubation period is, and secondly, when people can become infectious. Okay, and this forms key part of counseling parents of children who have chickenpox. So chickenpox, also caused by the Varicella zoster virus. Its incubation period can be up to 3 weeks. Okay, and people become infectious from a couple of days before they first start getting the lesions appear. Okay, and they remain infectious right up until the very last vesicle is crusted over. So it's quite a long window. Okay, and these are key bits of information to know when counseling people. And you essentially have to keep someone off school or away from work until the very last lesion is dried over. Now, for chickenpox, for the most part, treatment is supportive. Okay, we do not give anything other than maybe an antipyretic, which will usually be paracetamol for children with chickenpox. And the only reason we might give acyclovir is if somebody is an older teenager. If they present within the first 24 hours, we can give them acyclovir because there is some evidence that it reduces the rate of complications. But otherwise, treatment is primarily supportive, which essentially is just trying to get the children to avoid scratching. The evidence isn't too strong for using antihistamines. We definitely do not use things like calamine lotion anymore. So it's just a matter of trying to distract the child and just control any temperatures. There is a vaccine available, and depending on where you are from around the world and where you're listening from, you might have had the vaccine, but it is not routinely on the UK schedule, though it is available in places like Australia and in the Middle East in particular. But it is a very common infection, and it is one worth knowing about. So question 3, this is a slightly tricky one, partly because the image isn't the best quality, but hopefully some people can pick it up. It's a more of a stretch and challenge question. Okay. And we've got another mix of options here. So once again, there's around 25% of you who've each gone for options A, B, or C, 7% for option D, and 14% for option E. So the correct answer here is actually E. So the rash here seen is a rash that covers the face, goes up to the nasal bridge, and it also covers the eyelids as well. Okay, we can slightly see that this is the erythematous area, and this is what this girl's normal skin is like. Okay, so the diagnosis here, or one that would be one of the primary differentials, especially given that it's a face on her rash, and then there's a similar rash on her hands, is dermatomyositis, or in this case, this is pediatrics, juvenile dermatomyositis. Now, JDM doesn't typically have a characteristic antibody. It does have something called myositis-specific antibodies, and those are only present in around 50% of cases. Okay, but none of these options here are more likely than the ESR to be raised. So an anti-streptolysin O titer, that's for streptococcal infections. The ANA, that could potentially be raised, but not commonly. And that's more commonly seen in lupus, but you also have to bear in mind that ANA is a non-specific antibody, and we also have to consider what titer it is as well. So probably when you cover rheumatology and adult medicine, you'll learn a lot more about that. Anti-dsDNA is once again for lupus, and anti-Bergdorferi antibodies are for Lyme disease. Okay, now the reason these options are all here is because these can all be conditions that do cause a facial rash. Okay, so just it was tricky to find copyright-free pictures of children in particular with facial rashes, so you'll just have to use these ones. But one thing you might want, a typical question lots of people ask is, how might you distinguish between lupus and JDM? I think at your level, the key thing to bear in mind is the classical history, and the classical presentation will be JDM classically includes the eyelids, and you get that heliotrope rash. But of course, lupus would be a differential for this condition, for this presentation as well. Depending on your medical school, some may want you to learn the SLE diagnostic criteria. I do think that's a bit harsh. And just bear in mind with JDM, you don't typically get the majority of patients having autoantibodies. And if they do, there is something called myositis-specific antibodies. Other conditions you might want to consider with diffuse facial rashes when you're reading up is parvovirus B19, where they get bright red cheeks, scarlet fever, erysipelas, which is caused by a group A infection, and Lyme disease. Okay, so this is an example of erysipelas. And then this is also, sorry, this is example of scarlet fever, and the other one's of erysipelas. Okay. Question 4. Okay. Right, so the most popular answer this time is option B, 40% of you going for it, and then 25% of you have gone for options A and C, with a handful for the last two options as well. So yes, the correct answer here is a lumbar puncture. Okay, so over here you've got a febrile child. So any child who's born under 3 months of age must be brought into the emergency department. Okay, and they must have a full medical assessment. Now, the key thing we're worried about here is sepsis, and neonatal sepsis in particular. Okay, and if you are worried that the child is quite unwell and you cannot very readily find a clear cause for why they might have these temperatures, such as, let's say, coryzal symptoms, which means they've probably got something quite benign, you do need to do a full septic screen. And part of this includes doing blood cultures and a lumbar puncture. And given that the boy is around 2 months old, you probably can also do a urine culture as well. And those would be your baseline investigations. Okay, we do not routinely do stool microbiology as part of a septic screen unless you have reason to believe that there is a GI source and you're worried about it. And likewise, an abdominal ultrasound wouldn't really shed much light either. And we wouldn't typically do an MRI head or CT abdomen for this presentation unless we thought there was some sort of intra-abdominal pathology, or we were really worried, in which case we might do a CT head, but not an MRI head in the acute setting. Okay, so the key thing to bear in mind with neonatal sepsis is that any neonate with a temperature, you must tell parents before they leave the maternity unit that if they do have a temperature, do bring them in to the hospital where a emergency medic or a pediatrician can assess them. And depending on their age, will depend on which of the investigations we do. But as mentioned, typically you'll do a blood culture and a lumbar puncture. And especially if they've left the hospital and they've come back, you'd also consider a urine culture. But if it's the first few days of life, the NICE guidelines advise against doing a urine culture because it's rarely a UTI. Okay, you would only do a chest X-ray if you think there is a chest source. So you'll first do a clinical examination, and only if you want further confirmation of a chest source and your examination findings point towards the chest would you do a chest X-ray. Otherwise, we tend to avoid ionizing radiation in pediatrics. And then, of course, you just want to find any other source of bugs. So if you think there is a bit of skin or somewhere else that is infected, you would swab those areas. Now, your empirical treatment. So for neonatal sepsis for newborns, you guys will have learned it's Ben, Pen, and Gent. But if you are at all worried about meningitis, and especially as they've come out of hospital now, most hospitals will have empirical treatment of cephalosporin and amoxicillin. So we tend to use cefotaxime in neonates, especially rather than ceftriaxone, partly because ceftriaxone displaces bilirubin from albumin, and that's a worry for neonates given the immature blood-brain barrier and there's risk of them developing kernicterus. So cefotaxime is the preferred cephalosporin. And we tend to use amoxicillin to cover the rare instances of listerial meningitis. Okay, but most typically you'll see this as the empirical treatment. But depending on where you are, you might want to check your local guidelines and what your medical school teaches for what they say the empirical treatment should be. Okay, but the reason we do this and the reason we go all guns blazing is because neonatal sepsis is really hard to find the source based on clinical history. So that's why we do need to be quite invasive with finding these, getting microbiological samples of lots of different potential sites of infections. Okay. So 45% of you have gone for option A, 27 for option C, and then roughly an even spread for all the other options. So yeah, the correct answer here is discoid eczema, okay? And the key things that give this away are the fact that there are multiple lesions of a similar nature. They're circular, of a discoid shape, and that they're very pruritic, okay? Discoid lupus is unlikely given that there's no mention of any other systemic features, so you wouldn't make the diagnosis of discoid lupus purely in isolation. Tinea corporis may be another one, but we don't typically tend to see it in people of this age, and typically we don't tend to see so many lesions of this nature. Okay, but it too is also itchy and quite erythematous. And the other thing that points away from it is the fact that you can see this picture, and Tinea corporis tends to have a very marked erythematous ring with some very slightly normal skin in the middle. Okay, but this is quite classical of a discoid eczema. Okay, guttate psoriasis. So guttate means like raindrops. So you would actually see lots of tiny red lesions across the surface, and they wouldn't tend to be 6 centimeters in diameter. And warts, I think we'll just take a look at some pictures of warts. They wouldn't tend to be this speckled. They tend to get like very discrete, well-circumscribed lesions. Okay, so the most likely diagnosis here is discoid eczema. Okay, so the key thing to bear in mind with eczema is that it is itchy. Okay, and discoid eczema in particular is very itchy. Now, for the most part, the way we manage discoid eczema is the same way we manage just normal eczema. Okay, and you just go through the same ladder of treatment with regards to your emollients and steroids. So the key things to know for eczema generally, and this is essential knowledge for anyone treating children, is you need to know a bit about emollients and how to apply emollients. And then you got to know a bit about emollient and steroid ladders. So you start off low and you then go up, okay? And if a child does need a lot of steroids or needs steroids quite frequently, this is when you start going to specialist territory, and you can then start prescribing steroid-sparing agents. And going way down the line, there are therapies such as infrared therapy and monoclonal antibodies that are now licensed for children. But once again, you need specialist authorization for that. So the final points there are just something to bear in mind in the back of your head. But the key things to know about are how to use and counsel about emollients and steroids. The other thing to know about eczema is that we're worried about it because of a lot of the complications. So you can have superimposed infections on top of the eczema because essentially your skin is a really good protective barrier. And the issue with eczema is that it causes breaks in your skin. So the most classical bacterial superinfection on top of eczema is a staph infection, purely because staph is the most common commensal bacteria on your skin. And the most common viral infection is herpes simplex virus. So this is what we call eczema herpeticum. Now, both of these can make you really unwell, and they can produce like a bacterial or viral sepsis. So you can become really unwell with this. The other key complication with really widespread eczema is the risk of dehydration, because once again, you're having a break in your skin. And there's also a rare complication of eczema called erythroderma, which is an emergency. The final thing I put in here is something to bear in mind, which is that eczema is really itchy and it is really, really intrusive to people's lives. And it can actually disrupt sleeping. And this is something well worth asking about. It's actually mandated in the NICE guidelines for eczema in children, that you should actually ask about if the eczema affects the child's sleep, because this actually does form part of assessing the severity for eczema. So that's worth bearing in mind as well. And obviously having sleep disrupted will affect their behavior, their concentration, their performance in school, and a lot of other aspects of their life. So it's worth keeping an eye on that as well. Okay. And then the other thing worth mentioning with eczema is the fact that, like with almost any dermatological condition, it's very visible potentially. And that can make patients highly self-conscious about their skin, their appearance, and it can have a psychological impact as well. So sensitively exploring that is also really important. Okay. Going on to question 6. Okay, once again, got a good spread of answers. So 1/3 of you have gone for option C or option D, and around a quarter of you have gone for option B, with around 5 to 10% for options A or E. Now, the correct answer here is Streptococcus. So this here is a classical description of scarlet fever. And the key things that point towards this are the fact that there is this facial rash, and the thing to pick up is its maculopapular, but the fact that it is rough. And you might often read in textbooks that the scarlet fever rash looks and feels like a red sandpaper rash. And this is quite classical. And what helps further reinforce this is the fact that it's not near her mouth so it's what we call perioral sparing. So you'll see people with bright red rash on their face, quite rough, but around the lips and mouth, there is no rash. Okay, but when you do look at the oral cavity, it is bright red. Okay, and all of these things can be in keeping with scarlet fever, coupled with the fact that it's often caused by a streptococcal infection, often starting off as a throat infection. So you will get palpable cervical lymph nodes. Now, parvovirus can also cause a facial rash, as mentioned earlier. It typically doesn't make people this unwell, and the rash is not so rough, and so we wouldn't typically associate this with parvovirus. Measles, it is maculopapular, though once again we don't tend to see as rough a rash. And measles often it comes coupled with the 3 C's. So you have a cough and conjunctivitis. And then what you also have with it is it typically starts off by the ears or the face, and then spreads down the neck and across the torso. Okay. Kawasaki disease, once again, this might have some appearance of Kawasaki disease. The child's been febrile for 3 days, so not the classical 5. And the issue with Kawasaki disease is that children of Kawasaki disease are really, really, really unwell. So the fact that the child is relatively active is a very positive sign. And typically, if ever you posit a differential of Kawasaki disease to pediatricians, all they do is often take a quick look at the child. If the child is often sitting up and playing, you'll often be told that they're a bit too well for Kawasaki disease. Okay, but the description here does superficially tick some of the boxes for Kawasaki disease, but doesn't quite hold up to inspection. And herpes simplex virus. So no, it's not in keeping with herpes simplex. So normally the description you'd have for that would be you'd see 1 or 2 vesicles, or you might see a cluster of lesions, most likely around the mouth or around the lips, which just doesn't fit the description at all. So yeah, the most likely cause is a streptococcal infection. Okay, so scarlet fever, caused by streptococcus, otherwise known as second disease. I'm sure you guys all know you treat streptococcal infections with penicillin as the first-line treatment. Some of you might find this mnemonic helpful for scarlet fever. It's caused by a strep infection, which typically might start off as a sore throat. This is the perioral sparing I was telling you about. You do get a rash. You can get lymphadenopathy. Complications of some of the infection is driven by an erythrogenic toxin, and the tongue can also be bright red as well. Okay, and depending on where you're taught about infectious diseases or dermatology, or just a lot of these things, complications of strep infections can be wide ranging, which is why we really want to get on top of these infections when we pick them up. And it is not something to be taken lightly. While a sore throat might seem quite benign, the complications are awful. So yeah, it can locally complicate to an abscess, but afterwards you could, after the primary infection, you could get post-streptococcal glomerulonephropathy. And that is where the antibodies against the streptococcal bacteria, antigens, accumulate in your glomerulus, they get stuck, and then they activate your complement pathway, and it causes a lot of renal damage. You can get rheumatic heart disease due to molecular mimicry, and that can knock people into heart failure. And you can also get reactive arthritis. And a rare complication is something called Sydenham's chorea, where you essentially get, sorry, I've forgotten the mechanism for this now, but you essentially get a reaction happening in your brain. I'm not sure whether I think it is autoimmune mediated. And it results in some movement disorders, but that is quite rare now. Thankfully, all of these are rare due to penicillin. You now pretty much in the UK never hear of people getting rheumatic heart disease or Sydenham's chorea, and very rarely do you hear about people getting post-streptococcal glomerulonephritis. Okay. Question 7. Okay. So 1/3 of you have gone for option C, Ray syndrome, and then there's a roughly even split between options A, B, and D, and 10% of you have gone for options E. So the correct, so the diagnosis here is firstly, this child actually has Kawasaki disease, okay? And we'll go through the options, but the correct answer is A, peeling skin, or you might see this in your textbooks as desquamation, okay? Now we'll just go through the other options. So rheumatic fever is not something we typically see in Kawasaki disease. That was from the previous question where you might see it following a streptococcal or a poorly treated strep infection. The cardiac complication with Kawasaki disease is coronary artery aneurysms. Okay, and those in turns can cause other complications, including ST elevation in children, which is probably one of the only causes of it doing so. Ray syndrome is not typically seen with Kawasaki either. So Ray syndrome is a neurological condition that's poorly understood actually. There is some association between the use of aspirin in children while they have a viral infection and the development of Ray syndrome. So it's for that reason we do not give aspirin to children. But we wouldn't expect somebody to develop Ray syndrome if they have Kawasaki disease. Thrombocytopenia is not correct either. We'd actually see a thrombocytosis with Kawasaki disease, and we would not see aplastic anemia either. So the thing that might cause a rash and a fever and somebody getting an aplastic crisis, at least transiently, would be something like a parvovirus B19 infection. Okay, but the typical thing you would see with Kawasaki is peeling skin, and this does not happen early on. This is actually quite late on into the disease. As they're recovering, they will often, especially on their hands and fingers, you'll start to notice that the entirety of the skin on the hands can be peeled away. And it's quite interesting to see. It's quite satisfying after reading so much about it in the textbook, but it is quite a late stage sign. So you will never make a diagnosis of Kawasaki based on this. And just to reinforce the point, children with Kawasaki disease are really unwell. They're essentially flat. So in this case, he's had fevers for 5 days. And the classical history you often get is pediatricians will empirically start treating them for infections, quite serious infections. But despite this, their CRP will not go down, partly because the inflammatory process is not being driven by a bacterial infection, but by an autoimmune condition. Okay. So Kawasaki disease, the mnemonic I've always found helpful. There's quite a lot of mnemonics to memorize the elements of Kawasaki disease, but the one I've always found helpful and quite satisfying is crash and burn. So to make the diagnosis of Kawasaki disease, classically, you need somebody to have confirmed fever for 5 days, okay? And you need 4 of these things. So the conjunctivitis, okay, is a non-exudative conjunctivitis. There must not be any discharge from the eyes. The rash can be pretty much any sort of rash that does not have, that's not a bullous type rash. Adenopathy is cervical adenopathy, and it's usually unilateral. And then you get a strawberry tongue as well. So you get cracked lips and a bright strawberry tongue. And it's called a strawberry tongue because you can almost see the papillae being really big, so it has the appearance of a strawberry. And usually there is a rash or swelling of the hands or the feet. Okay, so this is what makes the diagnosis of Kawasaki. I put incomplete Kawasaki here as a red stamp, purely because there's been a move to try and get people to make the jump towards Kawasaki disease a lot earlier on to minimize complications. So you might see some people say somebody has incomplete Kawasaki if they match most but not all the criteria here. And that's something you might come across on the wards when you discuss things with your consultants. Now, the treatment for Kawasaki disease is high-dose aspirin and IVIG. Okay. And one of the main complications we watch out for is coronary artery aneurysms. So if you do suspect somebody has Kawasaki disease, you do need to get them an urgent echo by a pediatric cardiologist. And if they do have coronary artery aneurysms, they will then need to be under surveillance. Okay. Question 8. Okay, got quite a spread of options. So a third of you have pretty much gone for options A or D, and 15% of you have each gone for options B and C, and under 5% of you have gone for option E. So the description here is actually of quite a well child who just seems to have a non-blanching rash, primarily along their legs. So the child, and we can see that their observations are normal and that the flu-like illness a little bit earlier. So the key thing to point out here is that not every person with a non-blanching rash has, what you're classically almost behavioristically trained to think about is sepsis or meningococcal septicemia. So, we wouldn't typically give ceftriaxone to somebody fitting this profile. Another reason for non-blanching rash, which is the instance in this case, is ITP. Okay, and the classical description of somebody with ITP is often a child, and they often have had a flu-like illness, sometimes up to like 1 to 2 months before the rash develops. And apart from this fine non-blanching rash, they're otherwise completely well. Okay, and if you have ITP, that means you have low platelets, and essentially it's immune mediated, so immune thrombocytopenic purpura. And due to low platelets, you get all of these microbleeds that end up forming the non-blanching rash. And if you get lots of them in the same place, that's when they will merge. So that's where you start seeing the confluence. Now, for the most part, the management for ITP is purely supportive. Okay, we do not do anything. If we're happy with them, we discharge them and give safety netting advice. The only time we might do something is if the platelets are so low that we might consider giving IVIG or steroids. But I've seen children with platelets as low as 20, sometimes going towards 10, and even then we've held off. Okay, so for the most part, we don't give any treatment. The one time you might want to consider doing something is if there's a history of a catastrophic injury, or when you give safety net advice telling parents, you won't do anything, you will tell them if they do fall over or like bang their head, please bring them back, as we will need to monitor them and assess them. So you just want to make sure they haven't had a bleed in the brain. Now, what we typically would do is we would send them home and we'd have a repeat full blood count, usually within 1 week's time. And that's for 2 reasons. One is to make sure the platelet count is slowly rising and that it is not, or at minimum, it's not plummeting further down. And the other thing is what could be diagnosed as ITP could actually be the first element of bone marrow failure. So this could be the first sign that somebody has something like leukemia. Yeah. So as part of bone marrow failure, you have white cells, red cells, and platelets. And the low platelets could literally just be the start. And then perhaps after serial monitoring, you start seeing other elements of pancytopenia. Okay, so you'll want to monitor them and just do a repeat full blood count in a week. A bone marrow biopsy would be indicated only if you had strong suspicions of somebody having some sort of like bone marrow disorder, so things like malignancies would be the main one. And once again, you wouldn't jump to that straight away, and nor would it absolutely feature in somebody presenting like this. So I put this question here just for you guys to think about non-blanching rashes and consider that there are lots of other differentials for it. So when I teach medical students about this, this is a list that often comes up, and that's fine. And I think a lot of you might try and learn things this way. But if you look at this list, the diagnoses are generally quite separate. And if you know the basic history of each of them, it's quite hard to confuse them. So I would recommend when you try and look at non-blanching rashes is to focus on the history, and the history will pretty much rule out most of the other options. Okay, so we have ITP. HSP does have that characteristic non-blanching vasculitic rash along the buttocks and the lower limbs. You can get it from trauma or non-accidental injury, and that is something to always consider. Okay, and one thing to bear in mind is that you can get a petechial rash after prolonged or vigorous coughing. So if a child is coughing a lot, or if they've got something like whooping cough, they can get petechiae, especially in the superior vena cava distribution. So if they're petechiae from the face and the neck, that is because of the raised pressure, and you get all these microbleeds. But that is essentially a form of trauma, but it is not ITP, nor is it a form of abuse. Okay, so that's just something to bear in mind. And then finally, yes, a non-blanching rash can feature as part of somebody who has sepsis of any sort. So you will typically, people often say meningococcal septicemia, but just bear in mind, only 1 in 3 people classically used to get a non-blanching rash when they had meningococcal septicemia. So most wouldn't. Yeah, so it is not necessarily reassuring if they don't have a rash. But the prevalence of meningococcal septicemia is rapidly going down, and partly because we vaccinate against so many different strains of Neisseria meningitidis. Okay, but it's important to bear in mind that essentially any form of sepsis can cause a non-blanching rash, especially if it does progress towards developing lots of different coagulopathies like DIC. Okay, but this is just something to keep in mind that I think a lot of medical students often see the word non-blanching rash and they jump straight towards sepsis and jump straight towards ceftriaxone, but there are other things to take into account as well. And pediatric sepsis is a hot topic. It's always a hot topic. Unfortunately, it's a clinical diagnosis. We don't yet have a magical test to say whether somebody is septic or not. This is a graphic produced by a medical education group called Medisense, who have lots of great resources, so it's worth checking them out. And the latest guidance have actually updated. So you actually have 3 hours to initiate the pediatric sepsis 6 if you aren't sure if the child is septic or not. If you have a strong suspicion of a child being septic, you should do it within 1 hour. But the latest guidelines have been updated since this graphic was created a few years ago, and you have up to 3 hours. Okay, but the key thing to note is that the pediatric sepsis 6 is slightly different to the adult ones. And the key things to know is that part of it is a senior review that forms part of the 6. And obviously you will not be doing this as F1s, but children with sepsis, true sepsis, tend to deteriorate very quickly. So there's a consideration, which your registrars will be doing, to consider inotropes early. Okay, but all the other elements are the same. So that's just something to bear in mind. Final question. Okay, so 60% of you have gone for option A, 15 for option E, and then roughly 10% for the others. Cool. So the correct answer is option A. Okay, so the diagnosis here is Roseola. Okay, and that is generally a very benign viral infection. The key thing is the history here. So somebody having high fevers, being quite irritable, and then once the fever subsides, so in this case, there has not had any rashes since. The rash there, sorry, let me start again. The key thing here is when children have a high-grade fevers, are quite irritable, and then shortly after the fever subsides, they then get this widespread maculopapular blanching rash that is not itchy. And that is quite in keeping with Roseola. It is very benign, and you just need to reassure the parents that this will fade with time. So that's all you need to do. It is not a notifiable disease. And then all the other options are, well, fluconazole is for fungal infections, which is not the case here. We're not suspecting a bacterial infection or that she's quite unwell, so we will not give an antibiotic. And ganciclovir, we do not tend to give antivirals for this, and but ganciclovir would be an antiviral you might consider for certain types of herpes virus infections. Okay. So Roseola is caused by HHV6. It's called 6 disease. And this is a very, very, very classical pattern. When you actually do meet parents and see children with it, it pretty much follows this narrative so clearly, where they have fevers and irritability, and then the fever disappears and the rash flourishes. And as I said, you just got to reassure the parents. You don't need to isolate them. They can even go to school if they want, and it will all subside. Now, I've got this table here, so I'm going to leave it on the screen for a bit. I'm not going to talk through it as it's quite didactic, but I just put this together to help you separate some very similar presentations between Roseola, measles, and rubella. If you want to take a screenshot and stuff, you can, and I'm sure if you want to make notes on it when this video is up, you'll be able to do so as well. But the key thing to bear in mind is that Roseola is quite benign. There's no vaccine, it's supportive management, and no isolation is needed. Measles, super serious, highly, highly, highly infectious. You need to isolate. It's a notifiable condition. You can prevent it with either the MMR or the separate vaccines, and it has profound complications. Okay. And we need to have a vaccination rate of roughly 95% of the population to essentially protect the public from measles outbreaks. It's really infectious. And then you have rubella, and that's caused by the rubella virus. It is also a notifiable condition, requires isolation, also can be prevented with the MMR or the separate vaccine. And generally, people who get a rubella infection will typically be fine. The main risk it has is to those who are pregnant, okay? And that has complications for the fetus. So the main reason we actually vaccinate people against rubella is not for like the children getting the primary infection, but it's to protect vulnerable pregnant women. Okay. But that brings us to the end. So I just thought I'd show one more useful resource that has been floating around since I was a medical student. So it's quite old, but it's from a health authority near Manchester, because I always found it a pain to know about isolation periods for pediatric rashes in particular. So these are some of the ones worth knowing. I'd say it's worth knowing about chickenpox, impetigo, hand, foot, and mouth, and say, not mumps, how's it gone? Slap cheek syndrome, so parvovirus. And depending on where you get, so I don't know where you guys would have been taught your pediatrics or your dermatology, because these topics would come up either in GP or in dermatology or in pediatrics. Depending on where you get taught might depend on what elements of counseling you need to know. But I found this graphic quite helpful. And once again, you might want to screenshot it or make notes on it later when you get the video. And then finally, some useful resources. So dermatology is a very visual subject, obviously. So the really accessible books, I'd recommend one of these two, either Derm at a Glance or an illustrated color guide. Your medical school library should have ample copies of them, probably online as well. The other really useful resource is produced by the British Association of Dermatology. If you literally just Google this, you can download an entire PDF designed for undergraduates on basically dermatology, and it's perfect for your exams. And then I'm sure you guys all know about DermNet, which is a New Zealand website, once again, perfect for undergraduates, and patient.info for UK guidelines. One thing I really do want to emphasize to you guys is this website called Skin Deep. It's produced by a pediatric online education group called Don't Forget the Bubbles. And it's really kicked off in the last 1 to 2 years. And I must admit, I'm still learning a lot about dermatology. But one thing that was always a conversation when I was a medical student is the fact that most of the textbooks only tend to show rashes quite often on pale Caucasian skin, and you don't often tend to see what rashes look like on people who have different degrees of pigmentation. And That's something that you will often see written as a letter in medical journals by medical students every couple of months. And it's an ongoing issue, but there is efforts being done now to diversify the content scene. And I must admit, it wasn't until last year that I first saw a rash on somebody of Afro-Caribbean descent, and I had no idea what it was. And it actually turned out to be chickenpox. But I just really wasn't used to, I'd never seen somebody with chickenpox on really dark skin. And this website is fantastic. It's free and has lots of useful pictures of lots of rashes of different severities on all different skin types. So I'd highly recommend this. It's really important, and I still frequently go and double check things on there. So I do hope you get to use it, and I do hope as time goes on, textbooks will start incorporating a more diverse range of pictures. Because the presentations do look slightly different on different colored skin. Okay, I think that brings us to the end. If we stop recording, and then I'll answer any questions that people have posted.